Hi, everyone. Thanks for joining us. My name is Stephanie Shushan, and I'm from Community Health Plan of Washington. So I just wanted to thank you guys for joining this presentation on behavioral health integration and primary care. This presentation is a collaboration between all of the Medicaid Advantage organizations, as well as the Bree Collaborative and AIM Center, to share this information out with providers in support of your efforts integrating behavioral health in primary care settings. So as a reminder, this webinar is recorded. It will be available afterwards. You should also be able to see the slides and handouts within the GoToWebinar platform, and those will also be available after the presentation. In terms of questions, if you have questions throughout the presentation, we will be looking at those at the end of the presentation. So please put in your questions throughout as the presenters are going along in the questions or in the chat, and we will look at those after the presentation. So I'm going to go ahead and get started. Just a quick overview of the objectives for this presentation. We're going to have an overview of the Bree Collaborative and a variety of models for integrating behavioral health into primary care, and best practices for implementing those models. And then we'll have two presentations, one around behavioral health integration in a pediatric practice and one in an adult practice. And then we'll have questions at the end. So quickly, our speakers are Ginny Weir, she's the director of the Bree Collaborative. Sara Barker is the assistant director for implementation at the UW AIM Center. Jennifer Polley is the medical director for Northwest Pediatric Center. And Tree Normoyle is the behavioral health director at Valley View Health Center. So I'm going to pass the presentation to Ginny.
Thank you, Stephanie. I'm Ginny Weir. I'm the director of the Bree Collaborative, and I'll talk just briefly about what we are, our background, and then our work around behavioral health. So we're a public-private group formed by our state legislature in Washington to improve quality, outcomes, and affordability within healthcare. So we have 22 members who are appointed by our governor representing different healthcare sectors, so health plans, healthcare purchasers, both public and private, so our state Medicaid agency, as well as private purchasers like Boeing, Microsoft, and SEIU 775, as well as representatives from delivery systems across the state and quality improvement organizations. So every year we select healthcare services that have variation in delivery or outcomes that are used inappropriately or too often, not used enough, have a patient safety issue, or have an equity issue that the community really cannot address in any other way. So after selecting topics, we will form a clinical committee or work group to develop our recommendations. And our work is really based in evidence, and we have this reproducible process for developing guidelines. Our members, of course, are all volunteers, and they'll meet for about 9 to 12 months to look at ways of impacting change and then what that change should be. The work is really developed from the ground up by clinicians, administrative experts, and patients, for clinicians, administrative experts, and patients. It's not the state telling anyone what to do. It's really developed by the healthcare system. So we will review published literature, guidelines from specialty societies, the work of other groups, national entities, and then other programs and policies within systems in our state and then across other states. So we'll start by identifying problems and then developing a framework from which to work. And there's really this balance between standardization and individualized medicine that we really try to hit with all of our topics. And we also have to create something that works, that's attractive to clinicians, payers, and patients. And the collaboration piece, of course, always means compromise, as I'm sure everybody knows. So recommendations might be too innovative for some, but might not go far enough. And that's really where we try to hit that sweet spot. And then, of course, there is a difference between this guideline development piece and the implementation piece. Our primary implementation pathway is through the healthcare authority. They're meant to incorporate our recommendations into their purchasing contracts. But outside of this public purchasing, we can't mandate adoption. So we do a lot of convening and outreach and education. We also try to set a community standard of care for the whole healthcare community. So you can see we've worked on a wide variety of topics, starting with obstetrics, looking at appropriate C-sections. We've also looked at topics like low back pain, which is really important to our purchaser members, and things like end-of-life care and ways to increase advanced care planning. Our largest topic areas have been around chronic and acute pain, behavioral health, which I'll talk about today, surgical procedures, and especially bundled payment models and warranties. And we try to be responsive to topics identified by our community and state agencies, really honor the experience and input of our members as they select our priority areas. And you can see the topics in blue are those that we have worked on this year. So behavioral health has been a focus of our collaborative since our first work in 2016. And we've also developed specific pathways for suicide care, for screening, brief intervention, and referral to treatment for alcohol and drug use, and also for opioid use disorder treatment. And many of the elements within behavioral health integration, like team-based care, really apply to most care across Washington state. And many of our work group members and Bree members have said that if you can do behavioral health integration right, you can really do anything from high-quality palliative care to caring for those with Alzheimer's, because you have these necessary structural components in place. So our behavioral health work group started with the goal of developing a common language to really define behavioral health for our whole state. And our goal is a healthcare system across the state that places the patient at the center of care, that is accessible, and that's supportive to the provider community as well. And we really work to address the barriers to this whole person care. So this unmet need, this lack of information sharing between sites, this lack of a common language, and then of course a workforce issue. So this image here that you see is our conceptual model of behavioral health integration. So really incremental steps that delivery systems like plans and purchasers can take to work towards full integration. And we often speak to the clinical components that should be included within primary care. We really want to not overburden primary care providers. We want to create a system that is sustainable for everybody. So we define integrated behavioral health as team-based care that's provided to people of all ages, families, and caregivers in a whole person-oriented setting by licensed primary care providers, behavioral health clinicians, and other care team members that really work together to address all the components of a person. So mental illness, substance use disorders, health behaviors, preventative care, physical symptoms, and then patterns of healthcare utilization. So this is our grounding philosophy and really our touchstone for developing our 8 elements or focus areas. So we drew from national and local standards for integration and national and local initiatives to integrate behavioral health. So our perspective is that integration of behavior and physical health has been helped and hindered by the availability and use of these different models. So we moved to describing functions or really minimum standards that can be used across settings. Our goal is that practices would not have to hire additional staff to meet the model that we're talking about. So we really base this in trauma-informed care, and we draw from the collaborative care model, the AIM Center, other models in our state, and then patient-centered primary care home program in Oregon. We really like to steal ideas based on evidence where possible. So our goal is that these 8 elements allow providers and practices to know when they've achieved integrated care. We also want patients to know when they're receiving integrated care, and then purchasers and health plans to know when they are buying integrated care. We want everybody really to be on the same page and move together to create the sustainable evidence-based change. And I'll talk a little bit in more detail about each of these 8 elements. So this is a roadmap for the community, and all of these are laid out in the recommendations. We wanted to offer kind of a ladder to delivery systems to identify where they are and work to move from usual care to fully integrated care. We also felt it was very important to ground our language in the experience of a person receiving care. And so you see this patient perspective clearly listed next to what this looks like operationally. So I will briefly talk through these. So we start with integrated care team. This we feel like is one of the most important elements to truly have integrated behavioral health care. So here, each member of the integrated care team has clearly defined roles for both physical and behavioral health services. Team members, including clinicians and non-licensed staff, understand the roles, and they participate in regular practice activities like huddles and quality improvement. So from that patient perspective, it's really that I can see how my care team takes my concerns into consideration when making decisions. I can talk to members of my care team about my concerns, including feeling low or depressed or concerns about drinking, and they're really able to answer my questions and help me get treatment if I choose to. And then this patient access to behavioral health is a routine part of care, also very important. And at a minimum here, we want a care plan to be developed on the same day that includes continuous patient engagement in ways that are really convenient to patients. So that's our real minimum standard there. The accessibility and sharing of patient information was really meant to address this barrier with information being available. We heard that very clearly and strongly from the community, and so felt this is very important to include. So here, this is access to actionable medical and behavioral health information via a shared care plan at the point of care, and that clinicians really work together via regularly scheduled consultation and coordination to jointly address a shared care plan. We also really believe the practice needs access to psychiatric services, so that they're available in a systematic manner to assist the care team in developing a treatment plan and adjusting treatments for patients who may not be improving as expected under the current plan. And then for patients with more severe or complex symptoms and diagnoses, that specialty behavioral health services are readily available, and really that it's well coordinated with primary care. This all needs to be supported by operational systems and workflows that support both patients and the providers on the care team. So here, this is proactive identification and stratification of patients for targeted conditions. There are clinical protocols in place based on screening results and other patient data. So these can be things like PHQ-9 screening or emergency department use that help to characterize patient risk and complexity of needs. And that patients are tracked to make sure they are engaged and have a proactive follow-up plan to assess improvement and adapt treatment accordingly. Interventions should be based in evidence, and they should be appropriate to the practice and to the patient. So this includes things like language and cultural background. And then our last two are involving the patient in care, and that patient goals really inform that care plan, and the practice communicates effectively with the patient about treatment options and asks for input and feedback into care planning. And then this is all supported with data for quality improvement. So system-level data regarding access to behavioral health, patient's experience, and patient outcomes are tracked, and if goals are not met in a systematic way, there's quality improvement efforts employed to achieve access goals and those outcome standards. So very briefly, those are our 8 elements. I also wanted to mention our new implementation work. So we received funding to focus on moving our guidelines from the shelf to practice. We're very excited about that. And we have decided to prioritize behavioral health and also our work around value-based payment. So a big part of this focus on behavioral health is our pilot group. We've recruited 12 primary care practices who will receive high-intensity practice coaching and assessment to integrate behavioral health into primary care for 18 months, starting next month. And we'll also be supporting a broader learning community of practices across the state. We'll be supported by monthly webinars and our summit on March 17th. So look out for that information. And now I will hand it over to Sara with the AIM Center.
Great, thanks so much, Ginny. So I'm just going to spend a couple minutes talking a little bit about the collaborative care model and comparing it with the Bree recommendations. And you'll notice that there really are mostly similarities and very few differences. And folks from the AIM Center are really part of those recommendations, that group that made the Bree Collaborative behavioral health recommendations. So with the collaborative care model, you're really looking at two new roles into the primary care team, the behavioral health provider and the psychiatric consultant. Behavioral health provider most commonly is co-located as part of that care team at the primary care practice site. They don't have to be. The psychiatric consultant, though, has a role more in the population level, doing systematic case review, looking at the behavioral health provider's caseload of patients and working around measurement-based care, treatment to target, identifying patients that maybe need some additional support, different treatment approach, whether that be medication or psychotherapy. So having a registry to track patients, doing measurement-based care, using validated scales, doing evidence-based treatment are all kind of hallmarks of collaborative care model. Let's see, I think I switch slides, maybe. Oh, here we go. Whoops. So just people ask us a lot, you know, what is the difference, Bree versus collaborative care? And like I said, they're very similar. So doing systematic screening, having a behavioral health provider be part of that primary care team, doing measurement-based care, treatment to target. The one difference that I just want to highlight is around how we talk about access to psychiatric services. And so if you take a look at this slide, you'll notice under the Bree specifications when I talk about access to psychiatric services, it's really around, and that could be virtual or in person, it's around providing psychiatric supports to individual patients, so prescribing medications and treatment individually to a patient. And one of the key hallmarks of collaborative care is doing systematic caseload review. So usually weekly, reviewing the caseload with that behavioral health provider, making recommendations to that primary care provider. So sometimes the psychiatric provider can be available to see patients also in person, but a key piece of collaborative care is doing the systematic caseload review and making recommendations back to the primary care team. All right. I wanted to just mention a couple free resources here in Washington State. I always want to take advantage when I'm on a statewide webinar to talk about them. The University of Washington has a lot of funding right now from the Washington State Legislature to provide psychiatric consultation support to providers around the state, and we do that in a variety of ways. So there's the UW Psychiatry Consultation Line where you can call in with a patient case that you want to review with a psychiatrist. So this is for caring for adults with mental health or substance use disorders. There's also a line for providers who are caring for pregnant or postpartum patients, because it's called PAL for Moms. We have the Washington Partnership Access Line, or PAL. So that is calling in with cases with kids when you have a kid or an adolescent in your primary care clinic and you need a consult. And then finally, a couple other resources. There's one happening today, actually. It's UW PAC. It's providers who are caring for patients with mental and behavioral health conditions. There's a didactic piece where faculty from the University of Washington presents something around mental health or substance use. And then there's some case review time as well. And it's a great learning, and it's free. It's every Thursday. And then if you have a psychiatric provider in your community or at your practice that you're interested in training up more on Bree or collaborative care and how to do this work, there's the Community-Based Integrated Care Fellowship. Applications are now closed, but they'll be opening them up again next year. And it's a fantastic opportunity to trade up psychiatric providers around the state. All right, So enough from me. I'm going to pass it off to Dr. Polley now.
Okay, great. Thank you. And thanks for including us in your talk. I'm Jennifer Polley from Northwest Pediatric Center. And I just, not disclaimer, but one thing, integrated or our form of integrated behavioral health is the best thing we've ever done in our practice in all of our years. I'll just say that. So anyway, just to put us in context, we are I would say only pediatric practice. We see kids up to age 22. I guess they're young adults. We have, just because this is relevant to some of our issues, we have 4 locations in Lewis and South Thurston County. We started in '92. You can read all this. We are a rural health clinic, which for funding reasons actually does make a significant difference in funding behavioral health. We're 70% Medicaid and serving about 14,000 patients. And our practice size, you can see 18 providers, MDs and ARNPs. We have our mental health people we call behavioral health consultants, BHCs. We have 2 currently, and we just hired a 3rd, an LMFT. So anyway, she'll start in January. We do have a full-time child and adolescent psychiatrist, so that is a bit of a little twist, helpful for us. And then just context of services, we have a dietitian, lactation specialist, we have our own urgent care. The next page, this just shows the other specialists that come to our office or work out of our office. So again, this whole thing of trying to provide whole person care, especially in what we feel is a marginalized population of people. It's anyway, that's sort of our goal. We have an autism review team. We're a UW, medical school site, and we work in our local juvenile detention centers. So anyway, that's just a little bit about us. So now to this integration thing. So the question is sort of, I wanted to look at I'll go quickly through this because I'm preaching to the choir here, but we sort of started our path to integration. Well, we've always thought about it, but probably in 2017 in earnest. And the gap between services available and need in our community, as is true for those of you listening in, was just enormous. We were realizing that our mental health wait list for referrals out was at least 2.5 months. And if for our Medicaid patients, which is most of our patients, was sometimes even longer. We also had recently done in our community, our county, a community health assessment. And of course, we are one of the poorest counties in our state, and the needs both from whether it's mental health issues, drug addiction, et cetera, were very high and still are. And then there was the data, just 1 in 5 kids have a mental health diagnosis. The AAP came out with that statement, 70% of pediatric visits have an associated behavioral health issues. And honestly, we were feeling that burden, that we were being asked, as we all know, to do a job that we had neither were qualified to do or really were called to do. We were doing more and more mental health in our practice and realizing the impact on whole person of what mental health issues were bringing to, whether it's compliance or whatever. The other thing is that we had the issue of patient compliance, right? If you refer someone out, so we refer something to mental health, it took a while to get in, so sometimes you'd miss the urgent window, but we actually tracked our patients for about 6 months. So what % of people we send out actually go to one appointment? And our statistics actually are pretty good because the national average is 1 in 5 to 1 in 10 people follow through. We had about 25% that would go, but then they wouldn't follow through often after one visit. So there was and there's also, I'm sure this is everywhere, there's a stigma to mental health, right? So going to, I don't need mental health or whatever the issue was. So sending someone outside of our environment was an issue also. And then we certainly, as these words are used all the time, but provider stress and burnout is real, and it was probably, again, our biggest burden, besides EMR, which we all know, was that we were being asked to do above what we could do and not what we were trained to do. And feeling, though, not like, feeling that like we weren't doing our job well because we couldn't meet those needs. So we decided to go ahead and start looking at how can we get mental health. And I don't think I even knew a ton at that point about all the different models and what integrated behavioral health care was. But our initial idea was just we hire some therapists to come work in our office with us. And it would be sort of the siloed approach. But as I started looking at, this was in early 2017, started making calls, looking at different models, we realized that really was not, the data didn't support that, and it really was not the best model. So I actually just started picking up the phone and calling around the state. I talked to Ames folks, I talked to some different groups in Seattle. There were some pediatric groups that were having community mental health people, trying to have them come into their office. And then I got a hold of, someone recommended talking to Roy Sims, who is in the Yakima area, and they were working with this group that was doing something called the Primary Care Behavioral Health Integration Model. And at that same time as we were looking at models, we were looking at, okay, how are we going to get people? What resources are even out there? So we are also simultaneously calling, like state psychological association. How do you advertise there? How do you get to like programs that are graduating licensed mental health therapists? How can we get our name in there? Those kind of things. And then we also realized we would need grant money, or at least for us, having grant money to start our program and launch it might be helpful. So we were sort of doing those things, gathering data, and then we decided to, in that year, 2017, to jump in. And for us in our practice, we landed on this thing called the Primary Care Behavioral Health Integration Model. It was based on the work by two people, Robinson and Ryder, and they have their book, which sort of has become our guidebook, called Behavioral Consultation in Primary Care. And there was actually, the model is being used in, I think, in Yakima, in Central Washington Family Medicine, and then they have a pediatric practice. So it's a consultant model where the behavioral health consultants are integrated, but become like primary care providers. They're on-site, fully integrated. And I'll talk a little bit more about the model. And it was a very population health management-based model, and it seemed to fit better for us, probably because I didn't know enough. I know more about Ames now. But anyway, with us and our sort of more rapid pace pediatric population, we went and visited the site. We talked to there's a consulting group that works out of that place, and we decided to choose that model. And through the phone calls we were making to different behavioral health people and organizations, we did get a hold of a psychologist who was interested. We talked to her about the model, and which is, again, very different than how you would do a typical siloed practice. And she agreed to get training and jump in and try it with us. And simultaneously, we found a grant in our community through our county called 1/10 of 1%, doesn't matter, but that we were able to apply for and get. So sort of all these things came together, and in October of 2017, we launched started our behavioral health integration. A little bit about that primary care behavioral health model. Again, it is the primary consumer in the model is a primary care provider. So the behavioral health consultant's goal, obviously, is to help the patient, but also to support the primary care provider to manage behavioral needs of their patients. And as I said, it is obviously a patient behavioral health management model. So in its purest form, which we don't follow, would be making small changes to a large number of people. We did, as I said, launch in October, and right before, I think the most important thing, oops, I'm sorry, I didn't change my slide. Oh, I get carried away here. Let me catch up with myself. One of the important things in launching was preparing both our staff, our providers, and our patients about what was happening. And I think provider buy-in, that has been an issue, and across the board that has not been an issue for us, I think, partly because of the upfront work that happened. I think our providers also were so wanting to have help. So we spent time with providers talking about what is this model going to be like? What is our workflow going to look like? What kinds of things can we refer to behavioral health? How can we help patients and lighten your load? And then we did patient education. We talked, and a staff education. Then we talked to our patients, and we put it on our webpage and Facebook. We did like little video snippets on Facebook about what it was. We put up signs in our exam rooms. So I think we did a fairly good job of getting the word out. And then when our behavioral health consultant came, she did not start right away, right? We took a couple weeks to develop with her and our management team, develop a team, making sure who's on the team. We're going to meet every week because it is a new model, a new system. She shadowed providers to get a sense of who they were, and they understood who she was, met everybody in the staff, that kind of thing. And then, so that was sort of our beginning. And now what I was going to do next is sort of just talk briefly, I'll try to make this fairly quick, about what integration looks like. Now we're 2 years into it, and we've just hired a third person. So I thought I would actually take the different points that were talked about, the key elements of the Bree Collaborative, and just talk about what that looks like for us. So I think when you come to, integrated care team, and as we was talking about just a little bit ago, it really is about really clearly understanding each other's roles. So we have our behavioral health consultants, our PsyD and LMHC, and then we have our pediatricians. And we're very clear on and constantly understanding better what our roles are in that. The behavioral health consultants in this process are a part of our daily routine. They sit with us, and we have each office has a large provider office where everybody sits together. Behavioral health consultant sits with the providers. They are integrated into, and I'll talk about that as the second point, where there's our third point, sharing of information. We share chart space. So behavioral health consultant and the PCPs all write in the same chart node. It's just right. They have their own templates that we develop for them. And in that template, just so you know, they they do their assessment, but then there is a section where they put plan for the PCP so that they're helping. And there's a lot of, because we're together in the same office, there's dialogue back and forth all the time about patients. So they also, as part of this sort of routine and integration, I'm sort of touching on the first 3 points, they will come in the morning, and the nurses will come in and sort of what we call scrub schedules. So they will look at all the provider schedules that are in their office for the day and see who might be appropriate for help with behavioral health, or maybe who they could go in and see before the primary care provider to help ease part of that burden. Now, we do have outline clinics, which I'll talk about in a bit, but if you're in an outline clinic, then we have capability of telehealth and having a patient talk to the primary care, or the BHCs in our main offices over telehealth. And then the other thing we do as part of that, again, I'm addressing sort of the first 3 things that we, if I'm in a room with a patient, and I'll talk a little bit more about workflow, but what I would do is I would just text the behavioral health consultant if I have an issue, whatever I'm doing. It's a toddler with a temper tantrum that the parent it's beyond, or they're at the end of their rope, or someone who's not taking their medication or whatever. I just text the behavioral health consultants, and they try to answer within 5 minutes. And one of them, if they're available, will come right away and see the patient. So that's sort of how that integration works. And again, when we talk about patient access, the behavioral health consultant is on site, and they have quick access to them, hopefully same day. We actually looked at this, and if we, over the last 6 months, we've looked at this. If we refer someone out to our behavioral health consultant, they have about a 30 now to 50% chance of going. That's improved. But if obviously, if we do a warm handoff, they come right away, or if they can't get in right away, we refer them back to our BHCs. They have a 90% chance of coming back and see them. And we try to do that within the first few days after they're referred. That is not working well right now because we're shorthanded. And then as far as practice access to psychiatric services, since March of this year, we have had an on-site psychiatrist. So that, she is now full-time. So the way that works for us is that actually our BHCs have consultant time set aside each week with her, but that all of us message providers, we can just stop in and talk to her, or message back and forth. So it's a different model because we have her on site. They do consultation with her on difficult patients, and we do have a workflow for her. You see the BHC first in general, and then they can go to the psychiatrist. As far as workflows, I sort of touched on this, but we do have, and I'll talk about it in a minute too, we have screening tools just as far as when a patient comes in. As for example, if you're 11 years and older for a WellCare check, everybody is going to get we do use a PHQ-8, but it's basically a PHQ-9 for adolescents, as you know. So everybody gets one of those tools. There's certain things that we're looking for so that if they screen out for needing help, that we're alerted to get the behavioral health consultants. The way it works again in our office, if I see a patient and either they screened out on a PHQ-9 or whatever we talked about yesterday, we had a kid with a BMI over 35. And anyway, that was, so what we did in that case is we text our behavioral health people. If they're available, they come right in, they will text back, come back, do the warm handoff. We as providers will send a note to our referral department, so we make sure those are tracked. The nurse actually enters the patient into the behavioral health person's schedule. Behavioral health person comes in and sees the patient, and then they decided that they will follow up, and their idea is that they would usually see patients 4 or 5 times, sometimes they do more, or they will refer out to an outside provider. If the behavioral health people are not available right away, then we will send a note to our referral department. Our referral department will call that patient and get them in with one of our behavioral health consultants. So we have, there's a lot of other workflows, and I'm happy to, if anybody wants to ask questions on that or whatever, there's a lot of iterations that we've gone through over these 2 years, but that seems to work well. And the beautiful thing, it is population-based. Our behavioral health consultants last year saw over 1,000 unique patients each, which is compared to what they would have seen in primary care, or doing it in a siloed practice is huge. We've looked at things like, we do track things like how many established patients they see, how many follow-up, how many new patients, and how many warm handoffs they do. Those are our 3 kinds of categories that we call that. We track how many patients they see a day and how many they see a month. And then we look at population penetrance, how many of our entire population has been touched by our behavioral health consultant. We do use evidence-based treatments. We have a toolkit with strategies, both CBT, DBT, and solution-based therapies, and obviously they are, they pick whatever is needed for the individual. The patient is involved in care, and the beauty of this model, and maybe others, is that it is very patient-centric. It's a fairly, there's something called a contextual interview, and the whole idea is to find out with the patient or the parent, right? What are your goals? What are you hoping to get from today? And what do you want to work on? So the patient has ownership on that. The goal is identified, and then in follow-up, the goal can be followed up. We do, by the way, do patient satisfaction screenings every 6 months. I just did 100 patients, and I would say it's on a scale of 1 to 5. Patients, almost without exception, are thrilled and feel that behavioral health, the work our behavioral health people are doing has really helped them. We also use tracking and screening tools, and you can see the pretty standard. The PSC-17, I'll just say that's more of what we as primary care providers use. The other screening tools are what we all use, and those are all, we have now a graph for our front staff, depending on what the chief complaint is or issue. The patient is given certain screening tools if it's a new appointment or follow-up. And then, of course, we have access to using tools in the room, too, if the patient didn't get them. But it's pretty standardized at this point, and we just introduced the SMFQ in the last couple months, so that's our newer tool. We also use we worked with AIMS this year, which was really great, just to try to understand if there are ways to integrate any of that into what we're doing, because none of these models have been totally pediatric based. We've been using the caseload tracker, which is great for tracking our PHQ or some of our screening stuff and seeing how people are doing. I think for us, because we're not using a psych consultation model, we are now in the process of developing our own tool using some of the AIMS stuff that will just be in our own EMR. So we use OP, by the way. And then lastly, I'll be quick here. Our challenges, always the lack of community resources. So we are now faced with patients staying in therapy in our office longer than our model really would say, although we're okay with that because really the goal is to help patients. But I think that the goal is to get more BHCs, which we're doing, and that will help that. The challenge of having multiple offices, it is hard not to be face-to-face with someone. And so our goal, again, would be to have someone in each office. Always a challenge to recruit good behavioral health consultants, right? Care coordination support, we're in the process of hiring a social worker, but that would offload a lot of phone calls that our BHCs have to make. I think just for everyone out there, the biggest challenge is blending the mental health model and medical model, because mental health model is much better with boundaries. Medical model is not good with boundaries, and I think that tension and that change that has to happen with the model we're using is a hard one at times. I think quantifying success, tracking tools are great, but there's so many other successes that aren't quantifiable, and yeah, I just think that's a challenge, and the sustainability is always an issue financially, right? And then the successes, like I said, above all, the provider satisfaction it's been the greatest offload that we've had. Patient satisfaction, improved compliance with follow-through for mental health appointments. As I mentioned earlier, a significant increase to access to mental health, improved patient outcomes, and yeah, and it so far for us has been financially sustainable. So that's been a success. So anyway, thank you very much. I'm sorry if I took too much time, and I'll turn it over to Tree.
Hello, and thank you for everyone that's joining so early this morning. I really appreciate getting a chance to tell our story, and I hope it'll be helpful. So I'm a licensed clinical psychologist and a behavioral health director at Valley View Health Center, but I'm also a clinician that is providing integrated care, and I'm also part of the executive team at Valley View. And a little bit about Valley View, back in the early 2000s, there were some visionary community members in Lewis County that decided together to come up with a way to bring healthcare to people in the community, regardless of their ability to pay. And by 2004, they were able to establish a medical clinic that was a federally qualified health center, and we have grown from there. Let me see if I can advance slides. Here we go. So we now have 11 clinics, and we have grown from just Lewis County to be also in Thurston and Pacific counties. We have, as you can see, clinics that are located in some rather small towns. I'll pick a town there, Toledo. I think the population of Toledo is about around 700 people. And what we have found by providing, integrated care in the communities where people live, we have people that are accessing primary care and behavioral health care that would like that have been untreated for a long time. A lot of these folks have transportation issues, so if we can actually have a clinic in their community, it makes a big difference. The other thing that is so wonderful about having an integrated program in these smaller communities is, you get a lot of people that live in these rural areas don't think of, if they have depression symptoms or anxiety symptoms, they don't think of going and talking to a therapist about this, but they do think about going to their primary care provider, go talk to their doc about the symptoms they're having. And so it's really a wonderful way to break down barriers to access to mental health treatment. And so I would say, that's one thing that I think is such a strength. A bit more on an overview of Valley View Health Center. We have currently around 22 medical providers, and we are growing. We have 8 dentists, we have pharmacy now. You can see that we have 8 behavioral health providers. They don't all work full-time. So our FTE is about 5.4 currently clinically. Our ratio that I have found to be best practice for us is around 1 full-time behavioral health provider per 3 medical providers. Having that ratio really allows us to keep the components of a good integrated collaborative model working well, because then you have ability to do the warm handoffs and to communicate as often as you need to with the medical team. On my team, I have a mix of master's level clinicians, social workers, licensed mental health counselors, and marriage and family therapists. We have 2 bilingual therapists on the team. So we have all of our clinics, we have 7 of our clinics that have our integrated program. We are looking at ways to bring the integrated model to others that, are very small little clinics. And another thing that I think is a great step that we have taken is that we have 2 of our medical clinics on site or co-located with community mental health or BHAs. One is in Lewis County and one in Thurston County. And so we work collaboratively with these agencies, and we're really, there to make sure that we're providing primary care for, their patients that are, being seen by them that have chronic and severe mental health issues. But we also make sure that other patients that are from the community that are being seen at those medical clinics can access our integrated care as well. So it's like pieces of a puzzle that all fit together really well. We started our integrated program in 2009. It was a bit funny when it first started. I was the first person to really focus on, building the integrated program, and I was hired part-time, and no one really knew what to do with me. Thankfully, at the time, this was when CHPW and the state were working with rolling out the GAU MHIP program, and the AIM Center was involved, and I was able to get training, which was incredibly helpful. So I was the only one here providing mental health care. And one of the first things that became apparent to me that in my role is that it wasn't just about helping the patients, but it was about providing support to the medical team. We are a setting where there are a lot, I would consider us a training ground in a lot of ways for new nurse practitioners, new graduates, and they don't have a lot of training in diagnosing mental health. And so it was really apparent to me early on that a big part of what I was going to be doing would be providing support to the medical providers. And the other piece that I realized too is that they needed help with diagnosis. So a lot of patients were either misdiagnosed or on medications that didn't fit their symptoms. So we had an opportunity to really help, again, both patients from the community and the medical team. We had a wonderful opportunity in 2013. We were able to get a rather large grant that was to help us focus on treating people in the community who had depression. And with that grant came more intensive training on the collaborative care model from the Ames Center. And we learned some very important things from that experience. The one thing that I would say that has helped us to be successful is having buy-in from the top of the organization down. So we, the executive team and the board are, committed to making sure that we have a strong integrated model. At that time, we actually went to the board, the executive team did, and asked that we change our vision statement to include that we are an integrated model. The other thing that I think is really important that we've learned is that when you have a collaborative care model, that you don't get to a perfection point, a static point. It's continued fine-tuning. You are always growing, changing, learning. And even when you get one component you think is working really well, you have to always come back and give that attention. So it's a constant fine-tuning. The other thing that we have learned is that we need to onboard new medical providers. So they get scheduled with, as part of their onboarding process, get scheduled time with the integrated team to do training about the model, even as, in depth as how do you communicate to patients, about these team members that you have that will provide behavioral health. Because I think that if you can talk to the patient in a manner that lessens their fear about talking to a mental health professional, you're going to have better patient engagement. And the other thing that we've learned is how important it is to continue measuring quality. It helps you to stay true to the model. So our patients that are enrolled in our program, integrated program, we give them a PHQ-9 at each session that they come in. We track, the outcomes. We're working with the medical team and our consulting psychiatrist to adjust the treatment plan if we see that patients are not improving. We do use a patient registry through CHPW and the Ames Center, which has helped us, really understand how to, pay attention to those quality measures. The other thing I think one of our strengths is that we have had incredible support from our consulting psychiatrist. He is through University of Washington's Department of Psychiatry. We started out with him way back in 2009 with the GAU program, but we have continued working with him and have contracted for more of his time. He actually travels to all of our clinics at different times. He does a training usually quarterly, and he is available for the medical providers if they have questions. So I think I've talked a little bit about some of our successes, but another thing that I'm very proud of, and we've worked very hard to do, which is to build our part of our program for Spanish-speaking patients. We have patients sometimes that will travel over an hour to come to their behavioral health sessions, but it really helps with their medical treatment as well. And I would say that my behavioral health clinicians that are part of this the Spanish-speaking patient program have really helped the medical providers improve at, the medical plan. I mean, the outcomes of patients are better, is what I'm trying to say. And I think I mentioned that, again, access to care for patients in these rural communities who've never had prior mental health treatment. So, definite success is getting access to care for patients that would never have any other opportunity. We currently have just started a training program for new MSWs. We are doing this as a way to recruit and train, new graduates, new MSW graduates, and we have our first intern who's seeing patients. The challenges for us, I think, sustainability. We have definitely learned a lot about credentialing and billing for mental health services in this setting. There are many things that we do that, many touches that a patient has by the behavioral health team that are still not billable. We do have grants that we receive. And again, it is the commitment that this organization has to the collaborative care model that keeps us going. So we will always be working on that, on sustainability. I think another challenge is keeping all of the components intact. And I think Jennifer mentioned something that was important, which is, I think I'm getting a little feedback. Are you guys hearing that, or is it okay?
It's okay. It's okay for me.
Okay. We often get patients who come in for services, and again, we're a model that's focusing on treatment target and really symptom focused, trying to improve in a short period of time a patient's functioning. But we have patients who have pretty complex mental health issues at times, and it is hard to, in the midst of treatment, to say, okay, we're done. This is a limited number of sessions. So I would say that is a struggle for us. The other big issue that we have been facing is workforce. So again, we have this new training program we hope that will help us, but it is hard to recruit, especially to some of our smaller or more rural clinics. I think for an open position I had in Pacific County, I advertised for over a year before I was able to find a provider. So I think that's it.
Great. Thank you, everyone, for Tree and Jennifer for sharing about your stories and how you have gone about implementing integration in your clinics. So we do have, we have a couple minutes for questions. We also have a survey that will be sent out afterwards. You can put questions into there as well, and we can follow us that way. And I do have, there are a couple questions that have come through about billing. Let's see. And also substance use disorder. So I wonder in the next couple minutes if Tree or Jennifer, if either of you have any comments about treating substance disorder or billing within your model.
Sure. So, yeah, I'll start with the substance use disorder. So we in our integrated model, we make use of SBIRT, which is screening, brief intervention, and referral to treatment. We find that to be helpful, but then we do have to refer the person out. We don't have on-site treatment. We do have in one of our clinics, the one in Olympia, we are doing the MAT, medication-assisted treatment, for a small group of people that are enrolled in a program by the community mental health organization there. So we are exploring ways to, provide more services, but that's what we're doing currently.
Yeah, and I'll say from, so pediatrics, obviously it's a little different because the MAT is only for 16 and over, but you guys are ahead of us, but we're in the process right now of 3 of our providers are now certified to do medically assisted treatments. So we're working with because we also work with juvenile detention centers, so we're trying to implement it there as well. But we're putting together protocols right now that would, and working with a local, we have something called True North, and so our goal is to eventually have the treatment in our office and at the jails as well, and hopefully that will happen. I would think we've already got the okay from our legal system in the jail that would happen in the next few months, and then we would have therapists. Our therapists would not do that, but we would actually have people come in to work with our patients. So that's the goal. As far as payment, and Tree, you could probably know more. We are, because we're a rural health clinic, and probably even more so for an FQHC, we get an encounter rate. So in our system, LMFTs, LMHCs, LCSWs, and PsyDs are all included in that. So for most of our patients, we get an encounter rate when they're seen by our behavioral health. Now, we also, for the plans, they actually do pay a reasonable amount. Again, our Medicaid patients are all covered through our encounter rate, so that makes it a whole different ballgame for us. It's a gift, actually. But the plans pay fairly well based on time, and we have a limited set of codes we use, and I'm happy to share those for anybody who wants them.
And I would agree with what you said. And I didn't know if there was a more specific question about billing, because that's a big topic.
Yes, that's right.
Yeah. Well, for time's sake, I will wrap up. But there was a question about EBTs for the pediatric population, and I want to refer folks to the PAL website. So not only do they have phone consultations, but they actually do have a guide that includes some evidence-based practices and treatment and screeners for kids. So that's on the Seattle Children's website. So again, I want to thank everyone for attending and for your attention. Please, send other questions through our survey, and we will follow up to the questions that we may get to individually. So thank you.
Great. Thank you.
Mm-hmm.
Thank you.